Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
So hi, I'm Kelly Ramsey, and I'm an internal medicine and addiction medicine physician. And today I'm going to be interviewing Brianna Norton, who's the Deputy Medical Director for the New York State Department of Health AIDS Institute. And we're going to be talking about working with people who use substances. So hi, Brianna, welcome to the podcast.
Hi, nice to be here.
So first, I wanted to spend a little bit of time talking about barriers to care for people who use substances. So what do you see as some of the barriers to care when people who use substances seek services?
Yeah, sure. I think there's quite a number of barriers to care. I think first and foremost, people who use drugs unfortunately have experienced quite a lot of stigma or poor interactions with the healthcare system throughout their lifetime. It becomes difficult for people to feel safe when interacting with various providers. I think their concern is that no matter what the person is coming to seek care about, that the provider will solely focus on their drug use, if admitting to drug use or having drug use as part of their history in the chart. And often people who are using drugs, they do care about their drug use, and often they personally have a spectrum of ways in which they use drugs healthier or perhaps want treatment, but they're not always going into to the physician or the clinician or to the healthcare system specifically for that. And when their only interaction is people focusing on that, it can be really not patient-centered. I also think, unfortunately, despite an opioid epidemic, despite us really understanding that drug use has really hit every demographic in the United States, both racially, from age group, from living, unfortunately, there's still a ton of stigma around using drugs. And often the healthcare system can really sort of treat people with less respect than they treat others they perceive as not using drugs.
What do you think are some ways that we, as the clinicians or as the healthcare providers or as the nurses or other people in the healthcare system in that space, what can we do to combat that stigma and make people who use substances feel more comfortable in those spaces?
Yeah, I think first and foremost, we really have to, as a society, and particularly healthcare workers whose primary goal is to keep people healthy and alive, that we really need to just first overall recognize that drug use has really been part of the human experience forever. And that our brothers and mothers and nieces and everyone in our lives, have really experienced drug use in one way or another. That we have to start seeing this not as a disease of the marginalized, but really addiction as a disease of everyone, the same way we see high blood pressure or diabetes or other things that we really perceive as something that has affected large swaths of the population. This too has. So one is really normalizing the experience of drug use. I think the second thing is to do some education. So either self-education where you go out and seek education in drug use, to really go to some of the state education trainings that we do have available, but to learn about how people use drugs so that you can be educated on how to have them more safely use drugs. And I think really importantly is to educate yourself around the concept of harm reduction. So the idea that no matter where people are in their drug use spectrum, they may be at a point where they are not ready into treatment, but they really want to be safe as possible when they're using drugs. And we as clinicians can say, okay, you're here today for a toothache. That's great. That's what we'll concentrate on. But the second thing is, how can I help you use drugs safer for you? And one day that might be about educating people on not sharing drug using paraphernalia. But another day that might be the day they want to enter medication drug treatment. And having a spectrum, I think, is important. I also think I want to really emphasize that harm reduction is so often associated with drug use, when actually harm reduction is something that we as clinicians, as patients, and as humans really use throughout our entire life experience. So we don't tell our diabetics, like, if you ever eat cake again, I'm removing your insulin. Like, we expect that they probably will have sweets and cakes and carbohydrates. And what we tell people is, why don't you reduce that? If you love cookies, can you have cookies once a week? Right there is a principle of harm reduction that we just see is so normal, but somehow we stigmatize it when we relate that to drug use. And I think we need to be sort of normalizing that same spectrum as it relates to substance use.
The other thing that I think about are the barriers within the type of services or how the services are offered themselves. Can you talk about some of those barriers, and can you talk about the concept of low threshold services and what that means?
Yes. Unfortunately, our healthcare system is extremely regimented and rigid, and that really hasn't gotten better. It's probably gotten worse. And what I mean to say is you have to see a clinician for any problem, you have to, one, have insurance. The insurance has to be active. Then you have to make a phone call and make an appointment. Because of our sort of low number of availability nowadays, that appointment could be months from now or a month from now. You then have to show up in an extremely short period of time, so that if you then miss your window, you don't get to see the person. This whole cycle revolves again and again. Now, imagine if you're living in poverty, you are using drugs, and you have many of other really competing priorities, like taking care of a child and eating and making sure you have a roof over your head. Then those rigid services become even harder to access. I think from people who are highly educated with a lot of money and resources to make these, many people miss their appointments or are unable to do it for all sorts of reasons. So imagine if that's so much more difficult. And so the concept of offering low threshold care is really about meeting people where they're at. So if what we can do is, if the more walk-in appointments we can have, the better. The more flexibility around when people arrive for an appointment that we will still see them, the better. And importantly, if we could actually bring services to where people are already accessing, say, care and peer support. So if we could bring medical services to a syringe service program where people are already accessing different services, that really reduces the complexity of them getting care. If we can bring medical services to a homeless shelter, to an opioid treatment program, to other services that traditionally people who are using drugs use on a day-to-day basis, and lower the threshold to actually seeing a clinician, to being healthy, to getting medication, it can make a really large difference in their ability to access care. And I will say, as someone who worked at a syringe service program for a long time, there's this stigmatizing belief that people who use drugs are not interested in their healthcare or their bodies. And, I find it to be quite the opposite. If I would walk in as a clinician into the syringe service program, once people found out I was a clinician, everyone wanted to see me. So it wasn't that they don't want to see a clinician or want to get care or want to get their blood work. It's just that meeting those really high threshold, rigid requirements to do so was something they, were unable to figure out in their current life.
Some other things or practices that I've noticed that are also make care impossible to access is some clinics actually have a policy that if someone shows up under the influence, that they will refuse to see them, which again completely eliminates people who are actively using substances from accessing services. And another one was charging $50, $100 as a no-show fee if you didn't show up at your appointment or you gave less than 24 hours cancellation notice. And that included charging it to people who are on Medicaid, who obviously cannot afford that, but then it's on their record out the facility and they can't access care until they pay it. And so again, lots and lots of high threshold practices that make it difficult for people to access care. So I'm going to move on to our next question, which is, what do you see as some of the barriers specific to screening for and treating hepatitis C that people who use substances face?
Yeah, I think some of the biggest problems is that for such a long time, Hep C was a difficult treatment course. So it really, there was a culture that at that, maybe 15 years ago may have made sense where, Hep C treatment was somewhat of a risk versus benefit conversation because the treatments were so difficult and had a ton of side effects and their cure rates were not good. And that is no longer the truth in any way whatsoever. We now have super easy treatments that are just pills with very little side effects, and people are cured in 8 weeks. there's a lingering philosophy around Hep C for some reason among clinicians where they almost see Hep C treatment as optional, depending on where the patient is at in their life. And the truth is, Hep C treatment is a disease that leads to high mortality, liver cancer, one of the highest reasons for liver transplant in the whole country. So this is not and it's communicable, meaning we could transfer it to other people, right? So this is exactly the disease that should never be optional. We have a cure and we should be treating people like right away, rapid initiation, the same way we think of HIV. But I think there's a lot of clinicians that are unfortunately not educated around that at the moment. They don't realize that screening is important. They don't realize that the cure is really easy. And then on top of that, an additional issue for people who use drugs is many clinicians feel that you should not treat people who are currently or actively using drugs. Again, this is actually sort of counterintuitive to the philosophy of treatment. U equals U in the HIV world. Undetectable is untransmittable. So when we think about should we be treating people who are currently using drugs, the answer is an overwhelming yes. One, the New York State guidelines, the CDC guidelines, all guidelines suggest that people with active drug use should be treated for Hep C, but this is unknown. Two, we have really good data and really good medications to show that people who are actively using drugs actually do really well. And their cure rates are very similar to cure rates that are, in large pharmaceutical trials, even in the real world studies. And number three, we have really good data to show that after treatment, reinfection rates, although they do happen, meaning people do get reinfected with Hep C, we know that reinfection rates are very low, like less than 10%, usually around 5%. So what does that mean? Not the majority of people who are injecting drugs get reinfected. Not half of them get reinfected. Not a quarter of them get reinfected. I mean, we're talking 5%, less than 10. So 90% of them are not getting reinfected. So this is a really important thing. So there's a lack of education, I think, around providers. First of all, around how easy it is to treat Hep C, that everyone is supposed to be screened for a Hep C at least once in their lifetime, and that everyone should be offered treatment. And that reinfection, although it does happen, is low. And, I do also want to say that one of the things we say is that the only way we can end the epidemic of Hep C is to actively treat people who are currently injecting drugs, because those are the people who may transmit it to somebody else. So if we reduce the community Hep C viral load among a cohort of people actively using drugs, their viral load goes down and the transmissibility goes down. And so again, just people who use drugs, there's an ethical reason to treat them. There's a cure and they should not be withheld that cure. And there's a very strong public health reason to treat people who use drugs. And that's because if we want to end the epidemic, that's the only way we can do it.
I agree with all your points. And what I would add too is that if you never have a reinfection among your patients, that means that you aren't treating a population of people who are actively using substances. And so you expect that very low rate of reinfection. And most folks are going to change their practices if you educate them on how not to reinfect themselves, how not to, again, get a new infection after they've cured.
Yes, totally agree.
So the next question is, and we can chat together about this one, is what do you think are some of the barriers specific to pregnant persons seeking services, either prenatal care or substance use care, or getting information about hepatitis C? What do you think are some of the barriers that pregnant and parenting persons face?
Yeah. Well, unfortunately, as I mentioned before, there's stigma around, in general, there's continued stigma around people who use drugs. That stigma, I just think, is overwhelmingly worse for pregnant persons. We have a very sort of condescending parental approach to people who are pregnant. And that has always been the case. And unfortunately, if they're using drugs, they can experience just a lot of confrontational attitudes, a lot of stigmatizing attitudes that makes it very scary to enter the system. So the irony is that if we want people who are pregnant, who are using drugs, to get healthcare and to get healthier and to be part of the healthcare system, we actually have to reduce that stigma even more so that they feel comfortable entering these spaces that are going to allow them to be healthier. But instead, we intensify the stigma, which then allows them, which then makes it even more fearful to enter the system. There's a lot more criminalization of pregnant people who are using drugs. And so there's just a lot more, I think, fear of entering the system. And I know you've worked with a lot of pregnant people, so, I'm interested in hearing what you have to say as well.
Yeah, I agree with everything that you said. I think there's so much pressure on pregnant people in general to be perfect. So, people feel the need to call out people if they see a pregnant person having a glass of wine, smoking a cigarette. And again, it's sort of like the pregnant person's body becomes a public space open for comment instead of respecting the autonomy of that individual person. I also think that with respect to pregnancy and hepatitis C, that perhaps people who are seeing pregnant persons are not doing universal screening, but are rather doing risk-based screening. And we all know that risk-based screening is not effective because people have very real fears about consequences of being truthful, particularly about substance use and pregnancy. So it's really important that anybody who is treating pregnant and parenting persons, again, does universal screening for substance use that's based on a validated screening tool that's not on, subjective questions, and that's not done by urine toxicology testing. Urine toxicology testing really has no place in pregnancy, at delivery, or in postpartum persons unless there's actually a medical need to do that test. The other thing is that I think that maybe people are not familiar with the CDC recommendations and now the New York State Department of Health recommendations that all pregnant persons be screened for hepatitis C during every pregnancy. And the reason that is because there is a small but real vertical transmission. So from the pregnant person to the fetus or to the infant at delivery, it's about 6% possibility of that infant ending up with hepatitis C through the contact with their birth parent. So it's important. And it's important, too, that pregnant person either be linked during the pregnancy to an experienced Hep C treatment provider who can provide them with the information about getting them cured. And sometimes that'll be done during pregnancy and sometimes that'll be done postpartum. But really, it is incumbent upon whoever determines that Hep C diagnosis by doing appropriate screening and following up with a viral load. That is a closed loop referral, meaning that they follow up and make sure that pregnant or postpartum person actually made it to where they're going to get the care. The malpractice and liability lies with the referring provider. So it's not okay to just say, well, I made the referral, don't know if it happened or not, but I made the referral, but actually following up. Because as you mentioned, this is a curable infection. We don't get to cure things very often. And there's real morbidity and mortality associated with untreated hepatitis C.
Yep. There's still very low risk of the vertical transmission of Hep C. But if indeed that did occur, Hep C medications are available for children 3 years old and up. And that's, and so people should also be following the children. We have good treatments, we have good screening, and people should not escape, such sort of powerful medications. Yeah.
So we started to talk about the best practices when you were talking about screening and who to treat, but I just want to reiterate the points to just make sure everybody is really clear. So if you were to just summarize your key best practices with respect to screening and treating Hep C in people who use substances, what would they be?
Right. So all adults, as required by the New York State guidelines, all adults should be screened one time for Hep C. And in terms of screening for people who use drugs, certainly all people who use substances should be screened for hepatitis C. I will say you can do a Hep C antibody test, which is your initial screening. And that really just shows if the person's been exposed to hepatitis C. But it doesn't necessarily mean that they have the disease. So you do have to go ahead if their antibody is positive and actually get their Hep C viral load. The number of the viral load doesn't matter anymore. The meds are great for all viral loads. It's just, do they have a viral load or not? I also want to say that because about 25% of people can be exposed to Hep C and get rid of the Hep C on their own, or because now we've had medications and many people have been treated, if someone has active substance use and they continue to, you don't want to rescreen them with the antibody because an antibody is going to always be positive for them for the rest of their life. It is not protective. It basically is just their body saying, yes, I've seen this virus before, but I'm not doing anything about it. So if someone continues to use drugs, or perhaps they relapse after treatment, a year later, the screening test would then be a viral load. So anything further after cure, after treatment, or after their viral load is 0, you always want to do continued screening with viral loads. But again, all people who are using drugs should definitely be screened. And if they continue, then they should really be screened on, depending on their use, every 6 months, every year.
The other thing that I think some people may not know is that it really doesn't matter. While injection is the most effective way to transmit hepatitis C can be transmitted on any equipment that people use, regardless of the route of administration. I want to talk about that a little bit because some people may not be familiar with equipment used to prepare substances.
Yeah, that's such an important point. I always sort of go back into the 80s when one of the largest groups of people who were acquiring HIV, right, in the 80s were people who were injecting drugs. And because of syringe service programs and because of the work of activists and advocacy groups, we were able to get syringe service programs. And people, we've, effectively, other than small outbreaks, have really reduced the number of people who use drugs who are acquiring HIV. And why is that? People are not sharing syringes as much, which is the number one message we want to put out there. But interestingly, Hep C lives outside the body for a lot longer than HIV. And so there's these little cookers, which really in New York State, people don't need to cook their heroin, but they just need to dissolve it. But either way, it's where the cookers are where you put your drug in order to draw up the drug into your syringe. And many people are still, using cookers. They're not using the same syringe, but they're putting their syringe in the cooker together to draw that up. And many people are acquiring hepatitis C through sharing of cookers. And so really because Hep C is viable outside the body for so long, we really now know that it's not just syringes, it's the cooker, it's the cotton that people might use. In terms of snorting devices, it's even the snorting devices, potentially even smoking devices, sort of when people can often get glass can crack your lips or cause other abrasions. And so we really like to, and this is another reason to go out and educate yourself on how drugs are used and what is harm reduction, what is given at a syringe service program to help people use drugs safely. And that is more than just a syringe, it is all the other drug using equipment. So I always like to say, put down a newspaper, if you can get your hands on a newspaper anymore, but put down a newspaper and anything that's yours. And, that's your life, that's your drug using moment. And when you're done, safely discard of it. But all paraphernalia needs to not be shared, particularly with hepatitis C. And again, I want to just say that includes snorting and smoking when it comes to hepatitis C transmission.
And I think, too, people don't realize with HIV, it takes visible blood. So visible blood in whatever body secretion you're talking about. But if we're talking about hepatitis C, it can be microscopic blood, so not visible blood. And so that's why personal hygiene items can't be shared either with someone with hepatitis C. So clippers, nail clippers and toothbrushes and razors. So again, doesn't have to be visible blood to be infectious with hepatitis C. So people may not realize that. So as you were saying, smoking implements or implements used to sniff, again, doesn't have to have visible blood present to be still infectious. So I guess lastly, I want to talk about action steps for our listeners so that they can take away from this. So what do you think that providers and systems can do to ensure that best practices in screening for and treating hepatitis C in persons who use substances?
Yeah, a few things. One, it starts with education. So most practices have various ways that they provide continuing education for their providers and their staff members. And I think it's extremely important that they are up to date, not only the best Hep C practices, Hep C medications, simplified guidelines with hepatitis C treatment, but also that they really have a curriculum. And when I say curriculum, I'm saying 2-3 trainings, not months, but a curriculum around drug user health and harm reduction. So that is really an important part of continuing education for clinicians, nurses, and health systems. And again, this is drug user health and harm reduction is no longer a marginalized disease. This is a disease that has unfortunately become a widespread epidemic affecting every demographic. So no matter who you are, no matter if you're in the suburbs, if you're in the country, if you're in the city, whatever your clinic space is, you are going to be seeing people who use drugs, people who used drugs in the past, and therefore people who are currently living with Hep C. So we need to start with education. I think that it's a very important step is also to consider having all staff members, including front staff who interact first with their patients, to really be part of sort of what I would consider trauma-informed care conversations. This idea that we really, as a system, need to be destigmatized, understand trauma, and flexible in the way that we engage with people, all people, but certainly people who use drugs as they come into our system. That's really important. I think in one way to do this in an effective way is get Narcan from your local Department of Health, right? Narcan is used for overdose prevention. And teach your providers, one, how to use it, and two, that if they're giving out any type of pain medication or to give Narcan, or even not, if they could just give Narcan to serve all their patients. That's a way to quickly engage and say, hey, this is an epidemic in our country, in our city. I carry Narcan, you can too. This is one window into having a conversation that you may not have. As someone who works for the Department of Health, one of the goals I'd love to be able to, we do have there's been years when, and continuous, that say people who are LGBTQ have been felt marginalized in clinic spaces, and people are wearing, rainbows or having a rainbow flag or something to know in the clinic that it's a safe space. And I would like to be able to create, whether it's posters or little pins for clinicians, staff members, nurses, to explicitly say this is a safe space for these types of conversations to be had. I also want to really reiterate for anyone listening that it is one of the most rewarding things to be able to talk to your patients openly without stigma about ways in which they may not be able to talk to anyone else in their life. That conversation itself can be so empowering to people that they feel that they can take the next step to be healthy, whatever that is. And when people start doing better, it really is rewarding. And forget, hepatitis C treatment. I mean, it is very difficult to cure anything in healthcare. And to be able to look at your patient and say, you're cured. You don't have this anymore. Extremely rewarding for, I think, a clinician, but also rewarding for the patient-clinician relationship. Even the patient's relationship to healthcare can shift once they've gone through something with you, trusted you, and then were cured of something. So I think a trauma-informed approach, destigmatizing setting, education around specifically drug user health and Hep C, it can all be really important first steps into providing a more safe space for people to get into treatment.
Yeah, I totally agree with you. I also think that if people can leave their biases at the door and really ask about and listen to people's stories, it helps build that relationship and build empathy. The other thing that I experienced in treating patients was often people, not interested in addressing their substance use, but cured their Hep C and then felt like they were wanting or able to make changes because they felt better about themselves just from getting rid of the hepatitis C. So any last recommendations for our listeners before we wrap up?
I would just encourage everybody to go forth and treat Hep C. It's a curable disease. It unfortunately has a high risk of mortality and cancer. And it's one of the most amazing scientific progress that we have made in the last few decades is acquiring these really easy to use meds to cure a disease. Let's make use of this scientific progress and cure the patients we have. Currently in New York State, the estimates are we've cured only about 50% of people. And I know that we can do better. Learn about drug user health. Really remember that everybody is a human being and trying their best. So go forth with love and kindness, educate yourself, and hopefully we can end this epidemic.
Thank you so much. Really appreciate you chatting with me today.
Absolutely. Thank you for having me.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.